On this episode of The Nursing Home Operator, I sit down with Rob Zitsman, who spent more than 30 years in the nursing home industry as an administrator, operator, and now an expert witness. We talk about what he's learned over 3 decades in the business, why new administrators need to be a sponge, and why nobody has a monopoly on bright ideas. We also get into his expert witness work and some of the common mistakes he sees facilities make over and over again, along with the practical things operators do to avoid finding themselves in those situations. Let's get into it. For the people listening, so Rob has, I think it's safe to say, if I did my math right, he has over 2 decades of experience inside of nursing homes. Is that right, Rob?
Yeah, definitely. Actually, that's coming up. It's 31 years. It was basically March 1995. I set foot in a nursing home for the first time after working in hospitals for 10 years. I set foot in a very humble nursing home in Spring Valley, California, part of San Diego, as I always like to say, on the wrong side of Mount Helix. Now, Mount Helix, for people that know San Diego County, Mount Helix is nice. But I quickly learned nursing home work, skilled nursing, whatever you want to call it, post-acute care, it's retail. And we were on the wrong side, Campo Road. We were on the wrong side of Mount Helix. So yeah, that was my first entree into skilled nursing. And that was after working in basically inpatient acute rehab for about 8 years. And I really loved rehab.
That's awesome. Well, so if it was 95, then I cut you a decade short. So you have 3 decades worth of experience inside of nursing homes.
But it took me 2 years to finally get my license. It was a unique time, and I passed the federal test really easy. I took the state exam. I think I missed it by, I don't know, 2 points or something like that. At that time, it was 50 questions. You had to go to Sacramento. It wasn't online. It was on paper. You went to Sacramento. So back to what I was saying, it was a weird time. The state had a funding shortage, so I missed it by 2 points. Federal, I passed. But the next opportunity was like 9 months later. So I'm studying. I had my flashcards, my 3x5 cards, fly up to Sacramento, because it was in Sacramento. It was on paper. I go into the room. About less than 20 minutes later, I'm done. All that.
What was the flight for, right? If you wish you could take it online, right? But I guess that in 95, did they have online testing at that point, or?
No. Every 97, 96, 97, no.
Yeah.
And the state was under another budget crunch. But I passed, and the rest is history. And so, yeah, I've been almost 30 years, a licensed administrator, almost 30 years.
Love it. It sounds like the state has been under a budget crunch for 30 years then, because it's still under a budget crunch. So that's awesome. Well, I know we're going to jump into your background, but this is the nursing home operator. So we're going to keep it casual at the front, and we'll talk about serious stuff, but really we just want to have fun with it. So I've got a couple of hardball questions really quick right out the gate. Rob, what's the worst advice you've ever been given in this industry?
Maybe don't eat the meatloaf. I don't know.
Don't eat the meatloaf.
I don't know.
When really the meatloaf is fantastic in these nursing homes, right?
Who knows? Yeah, mystery meat. It's mystery meat. Who knows? When you're just totally new. I mean, obviously I'd worked in hospitals and stuff like that, and I think I was starting out in nursing homes. And there was this LVN, cranky old LVN at the facility in Spring Valley, and I go up to her. I said, "Well, tell me, what's the best kind of patient?" And she looked us dead in the eyes. She says, "The one with no family." And it's like, yeah, after a while, you realize, yes.
That is the truth sometimes.
So that was like some of the best advice. But anyway, worst advice? No, I've been very fortunate. I've had lots of good advice, including like, maybe you should think about doing something else. But
well, if you've been in the industry for 30 years, that was bad advice, because clearly you love it enough to stay in there for 3 decades. So
yeah.
All right. Well, then what about this question? I'll ask you a different one just to get things going. In your opinion, what's the quickest way to spike an administrator's heart rate?
That call you get, the receptionist says, "CDPH is here."
Oof.
Between that and there's a subpoena here for you. But which you take your pick. Somebody let me just tell you. So I'm brand new. Just started this job, and working in a nursing home, 95 March or something like that. It's like the end of April. I have no idea what I'm doing. And I'm sitting at my desk. I'm finishing a meal tray lunch, at the facility. And in walks these four people. And they say, we're from the Department of Public Health. We're here to do your survey. And it's like, you don't know what you don't know. So that gets your heart rating. I'll never forget this one surveyor. I used to sweat, never let him see you sweat. No, I used to sweat. And she said, it was like day 2 of the survey. The surveyor says, Rob, what are you sweating for? I said, it's just me. But yeah, that'll get your heart going.
That'll get your heart going. I feel my heart going right now. Anytime I hear the health department's there, I'm
Yeah.
concerned. Even though sometimes we're
Yeah.
100% ready to go, it's just having them in the building can get stressful. Let's jump into your background then.
Yeah.
What got it started and what's kept you
Well,
here so long?
what got it started was there was an interesting change happening. And I said I worked in inpatient acute rehab, fantastic level of care, hospital inpatient acute rehab. And what happened is organizations like Kaiser and other Medicare Advantage type programs, they did not believe in sending people to acute rehab. They were using nursing homes. And one thing led to another. In between jobs, the hospital I was with merged another hospital. It just nature of the beast of hospitals in the 90s, hospitals closing, hospitals merging. And I made up my mind, I've got to get into skilled nursing because that's where the rehab is, that's where the business is. And I met some people who were kind enough to give me I was in that first position about 4 years, and then ambitious. I went from the 75-bed building to a 220-bed building that no longer exists. And I had this
Yikes.
cranky DON who, she's looking at me like, what's this kid? And I wasn't a kid. I was in my 40s, but still, I mean, she says, he's only been in nursing home work for 4 years. I've been doing this for 20 years and blah, 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 blah. And man, that's where you don't know what you don't know. And that was kind of, I think, a point where during the first survey, I was there about 5 months, went into an extended survey. And it's like, I really was questioning, did I make the right choice? But you learn lessons. You get beat up and you learn lessons. And I persevered. That building's now closed. It's gone. There's a nice apartment building right near San Diego State where that building was. But yeah, you got to go through it, and it's not for everybody. It's not for the faint of heart. Let's put it that way. What
Yeah.
we do is so important. Whether it's short stay post-acute care or whether it's long-term care, we care for people whose bodies or minds have betrayed them. Now we know there's other people out there that have done themselves in on alcohol and drugs, but really for the most part, it's nice people that, you wish you knew what they were like 20, 30 years ago. And that's what's neat. And you meet so many nice families, and it makes a difference. You work your tail off. Everybody tries to give good care, and you don't realize the difference you've made typically until that resident dies and the family comes up and either gives you a hug, shakes your hand, and says, "Thank you, thank you for being there." I mean, I'm
Yeah.
telling you, that's the payoff. That's what it's all about. You can plan as much as you like, but you got to roll with the punches. You never know what's going to happen.
Can I actually take us back to something that you said? Because I think it's
Yeah,
super applicable, maybe just for me, but
maybe.
you mentioned how, as a young administrator, you were asked to go in and manage a team that had a lot more experience than you had. How did that go? And what are some of the tips that you have for guys like me who are young administrators coming in? We're asked to manage teams where our directors of nursing have 20 plus years of experience. What should we be thinking of and doing in those situations that maybe you wish you had done back when you'd first started?
Well, yeah, I think the thing to do is just be sure to ask questions. Always be a sponge.
Yeah.
Say, hey, why do we do it that way? Why is it this? And then you go back and you say, okay, well, and there's that old, Ronald Reagan trust but verify. I don't think began to become competent until I was about 5 years into being an administrator, until I'd seen enough, experienced enough, had a really bad survey, had some things kind of blow up in my face that weren't comfortable in terms of, whatever, and that's the best advice is as long as people see you as being fair-minded, open-minded, wanting to learn, wanting to roll up your sleeves, not just hiding in an office, I'm telling you that people will partner with you. And of course, the other thing you do is that you start out, you take a couple of weeks to kind of assess the situation, but you have a clear vision and be able to share with the team, this is where we're going. Yeah, I don't know if you ever watch Hard Knocks, if you watch HBO Hard Knocks
Yeah,
preseason,
definitely.
and every coach, it's like, this is about getting to the Super Bowl. This is
Yeah.
about, and it's about that vision. And this is how we're going to do it. That coach can't block, he can't tackle, he can't throw a pass, but he's got the vision, and if you share that vision, but then still be open to, nobody has a monopoly on bright ideas. And that's one thing I'll tell I remind every administrator, and I'll tell staff, I don't have a monopoly on all the best ideas. Hey, we need a lot of good ideas to find the great ideas. And I can't emphasize that enough.
Yeah.
But people will test you. They say, okay, well, I have an idea, and be careful. You don't just like roll your eyes. And I'm pretty expressive. And so at times I have to that's taken a lot of years to not roll my eyes and to be listen and say, and there's lessons you learn in improv. I'm sorry, I'm digressing in another area, but there's one rule of improv. The rule of improv is yes, and. It's not no, but. It's yes, and. Yes, that's a good idea. And, maybe what do you think about this? Or what else? That,
I love that. I love that a ton because I enjoyed doing improv and acting in high school and,
then
early in
you've learned that.
college.
Yeah, you
Yes,
learned that
and.
lesson. Yeah, yes, and it works.
Yeah, I also feel like people are so much more willing to buy into their own idea. And so if you can somehow loop in them to your idea, but have them give input, then they feel like it's their idea and they're so much more willing to buy in.
Yeah, yeah. Well, I think the late Stephen Covey said it, in his 7 Habits of Highly Effective People, which a lot of people may know, and you can
Yeah.
look it up on YouTube and watch, the whole clean and green. And his adult son now, who has the book, Speed of Trust. But,
Yeah.
it's like, you just look, this is what we want. We want clean and green. We want our residents to look good and smell good. And that was something I came up with about a year into my job. As I said, look, I want the facility to look good and smell good. I want our residents to look good and smell good. I want the food to look good and
Yeah.
smell good. Tell me what you need to make that happen. That's
Yeah.
that's what we're about. We want to look good and smell good. And over the years, I've had people come into my buildings, and I've had very old buildings. I've had buildings that when I first took over, you could smell the building from the parking lot.
Yeah.
And after a while, people come in and they say, the building doesn't smell. And it's not because you're using fragrance or anything like that. It's just because everybody's on board, and it makes a difference. And then, the other thing, I love when families will say, your staff are so nice. I go, yeah, give me a day. I'll work on it. I'll
Yeah.
fix it. But,
Yeah.
when staff feel supported and they have what they need, they're not running around looking for washcloths or incontinence supplies, and, they feel supported and they have equipment that works, they're happy.
Absolutely.
And it makes an administrator's life great. It makes a family's life great.
Yeah, I love that. I cut you off a little bit ago. You mentioned that you had some sayings, and if a podcast loves anything, it's sayings that make sense. So please hit me with these sayings.
I came up with this a long time ago. I call it the Swan Lake syndrome. And you're sitting with the family, and the family's telling you, if only you would give mom another, 30 minutes of therapy a day, she'd be doing great. Well, you just got to push her. Yeah, if only, we do that, then mom be ready to dance Swan Lake. It's just kind of like inside code, and there's the refrigerator rule. You gotta stick with the refrigerator rule. When in doubt, throw it out or get them out. So if you hire somebody, all I can say is, if you find yourself a week or 2 weeks or whatever, even 3 or 4 weeks into it, and you say, Bob's pretty good, if only. If you're saying if only, when in doubt, do yourself a favor. Oh my God.
Absolutely.
Because
Yeah.
everything's about the 80-20 rule. You know the 80-20 rule, Devin?
Let's hear it. I don't.
So 80-20 rule, so much things like, so if you're in an organization, 80% of your referrals, like a skilled nursing, 80% of your referrals in admission are going to come from 20% of the hospitals, 80%, you're in a not-for-profit, 80% of the money's coming from 20% of your constituents or your organizational members. When you're when you're a boss, when you're an administrator, 80% of your problems are going to come from 20% of your staff. It's 20. You could try to whittle it
That
down.
hits way too close to home, Rob. I can feel that. Like, I know that that's true. And probably 80% of the work gets done by 20% of the employees.
I think that's a little bit too harsh, Devin.
Well, in terms of when in doubt, throw it out. What have been, because I have this issue all the time, right? You bring in somebody who during the interview they just absolutely crush it, right? I'm so stoked that we're bringing this person in. It feels like I'm getting just like an absolute rock star. And then they start, and all of a sudden you start to see things. And then you have that sinking feeling in your gut, like, actually, you know what? Like, now I'm starting to see the real truth. What have you done in the past to actually uncover how that person is going to be as a full-time employee? Because it's so hard for me to get an understanding of who that person is in a half hour or even multiple interviews. What have you done?
I really look at the resume and I look at the work history, and it doesn't have to be in healthcare. I just like to see a track record of where somebody has either done philanthropic work over a long period of time, or been with one organization for a fairly long period of time, or has strategically developed themselves, invested in themselves, consciously made decisions that, okay, I did this work, and then while I was supporting myself to get my degree or get my LVN or whatever. So I like to look at that. People that work in the service industry, I'll tell you, I love somebody. If I see if they worked at McDonald's or they worked in retail, like at Target or something like that, and they've had to deal with people, had to work especially a front desk work at a motel, that I like that. But sometimes still you get square peg round hole, and it's not that often, but I have talked to actually some people. I said, you're one person. I just don't think this may not be what the right job for you. What do you think? And get them to open up and talk about it, because not everybody should be in skilled nursing. There's other opportunities. I'd rather, if I think somebody's a good person, but I realize that, help them realize they've made a mistake, that this isn't the right setting for them, I'm more than happy to help them and coach them. But the others, the others that just don't show up or late, and come on, that's the person that said, Gary's great, but she's always 15 minutes late. Come on.
Yeah. When in doubt, throw it out.
My bad. I own it. Own it. And you roll with the punches, because it'll, it is what it is. But you just, you learn lessons.
Absolutely. I've had to own many mistakes in morning meeting where I just walk in with a big smile because everybody knows what I'm going to say. It's like, that was my mistake. But you know what? We're going to move forward.
Your mistakes will drop exponentially with each year you're at this. As long as you're a sponge. You just be a sponge, keep learning, talk to your nurses, if you really have a medical director that takes a real interest in the building, that takes a real interest in, and is a professional medical director, these people will really help you and develop you, and it just makes a world of difference.
Yeah, absolutely. That medical director can be an awesome help. So, Rob, one of the things that I find fascinating about your career is you have gotten into this expert witness work. Tell me a little bit about, first off, what does an expert witness do, and how did you get involved
it was
in
something
that?
I felt like, you reach a certain point in your life, and now I am, believe it or not, I'll just tell everybody, I'm over 70. It is what it is. Time moves on, and you have all this wealth of knowledge and experience. And I just was finally in a situation where I felt like I could take on. Somebody called me about 2.5 years ago, said, "Hey, would you be interested in be available to do expert witness work?" And I said, "Yeah, I've been interested in it." And, I took my first case, and kind of the rest is history. I just was doing it part-time for the last 2+ years. And now that I'm quote unquote semi-retired, but whether you're working for the defense or plaintiff, something has gone wrong. And for the defense, you're looking at, okay, to what extent was the facility in regulatory compliance? Because as an administrator, you can't judge quality of care. You can suggest to the attorney may want to look at this, may want to look at that. We can identify systems. I can tell you, from a defense perspective for a facility, let me just tell you some things that the listeners may really value. Make sure that 48-hour care plan is done. Make sure it's more than perfunctory piece of paper. Make sure you understand what the expectations are, what the needs are, what the expectations are. And I would say as an administrator, you may not have to be in that meeting, but the very next morning afterward, hey, can you go over that with me? And I think it's so important that then everybody in the team know in the morning meeting, hey, we admitted so-and-so, we had the 48-hour, baseline care plan meeting, and want to share with the group, this is, make sure everybody understands what's going on. Because you're going to identify possible concerns, possible things that could develop. Another thing is sometimes you have long-term care patients that aren't doing well, and I can highly recommend a goal of care meeting. If you're not already doing goals of care meetings, it really is important, especially for families that still have a pulse, that still say mom should still go to the hospital if she's sick, something happens. And you want to know those people that are still, no, even at the end of the goals of care meeting, it's like, no, everything done. And your staff need to know, and your CNAs and the licensed staff need to know, because one of the biggest risks is not sending that person out when there is a change of condition. And you're not doing yourself, everybody worries, every hospitalization rate is such and such. You're not doing yourself any favor. But those people that I say, the family has made them DND. There's DNR, do not resuscitate. Well, some residents, their family had made them DNE, DND, do not die. So you're just not doing yourself any favor. And that family could end up, suing you. So, the care plan needs to count. Everything, make sure everybody's on the same page. And then as things pop up, talk them through. I think one of the best things that I learned early on, and this is the same person that told me about the bipolar patients, is Rob. He said, sometimes you just have to sit with the family and just listen and take it. And so that's one of the things I had families, and I would either on the phone or in person, and I'd be quiet and I'd write notes and I'd listen. So let me make sure I understand this is, and then once you have all that, and then a director of nursing taught me this. Well, what do you suggest we do? Don't waste your time trying to prescribe saying, well, we'll do this or we'll do that. Just say, no, I understand what you're saying. What do you, nobody can care for your mom the way you could. What do you suggest we do? Finally, these are gems that I acquired that people told me, because I've always been a fixer. The only other thing is competency. We do the facility assessment and we put competency. So if you're going to say, okay, well, we take care of paraplegic, that's going to be one of your competencies. Make sure that the staff really can care for paraplegics. Before there was ever staff competencies, like we admitted a Russian-speaking patient back to that same second building, whatever, cleared building, it doesn't matter. So we admitted this Russian-speaking patient. And his son said, his son lived like 10 minutes away. He said, I'll translate. Well, lo and behold, after about 6 months, his son calls licensing, and licensing says, you shouldn't have admitted somebody you can't, for whom you cannot provide appropriate care, you can't translate. Just save yourself some headaches, I think as an administrator, you respect your staff and you bring in appropriate residents. Hindsight's 20/20. We always get somebody that we bring in and they're mean, it's a mean son of a gun, the family's mean. It's like, okay, you support the family through it. But again, just respect your patients. Don't just bring in train wrecks or somebody who's been at 3 other buildings, but now they have 100 medical days, so you're going to put them in your building.
Yeah. Well, Rob, let me ask you this. If you could go back, right, and you're a young administrator, what have you learned from these, moments where you're an expert witness that you would do differently from what you had done?
Just be more thorough, be more involved. You understand where the risks are. And we've gone through a lot of changes, When I started, we used posy belts, posy belts in wheelchairs, belts in bed, and now we have people, every once in a while there's a fall and I go, where's the Velcro? Can we at least get some Velcro to put on? But on them, they don't
Yeah.
get out of bed. But there's been so many changes, that I, you just have to experience it.
One of the benefits of working in an industry for 30 years is you're able to see all these changes that have taken place. What's been the biggest shift that you've seen over the last 30 years in
Well,
nursing
I
homes?
think the restraint-free environment, and I'll tell you, I was right there when we stopped using side rails, and I thought, oh no, people would be on the floor all the time, and that didn't turn out. But I think that one of the best thing has been polypharmacy. Uh, the number of medications that people used to be on 20, 30 years ago. And even now, there's people that are in a standard, Medicare fee for service system, and they go to all the various ologists, the neurologists, the cardiologists, and whatever, pulmonologists, and they have all their medications, and they don't have a quarterback overseeing their meds. And it's one of the things we can do uh, is deprescribe and I was also very apprehensive about the move toward reduction of psychotherapeutic medication. But again, you really start supporting your staff, having the right non-pharmacological interventions. It's not more than you talk about. You put together toolkits, you put together supplies so that, and the CNAs, that you give them the education, you support them, and they know, okay, well, Mary's really acting out. This is what, this is what helps her. Let's get her some hot chocolate, or let's give her this book. She may not read, but she likes looking through the pictures or whatever. So it's been some of the best, I think, things that we have done. But the whole healthcare has evolved.
I'm going to ask you to put on your speculation hat now. What do you think the next big shift is going to be over the next 10 or so years
Yeah,
in
yeah.
nursing homes?
So let's take I'll just take a big picture, because we have a whole wave, the silver tsunami. Yeah, silver tsunami. We got the silver
Yep.
tsunami coming. We're going to find people that need long-term care, cannot afford to be in assisted living. So what I really see happening is that we get on board with the assisted living waiver programs, where every state across the country, that we realize either we ask some more resources for people to stay at home, although that's not necessarily cost effective. It's fine for people that need occasional help during the day, but people need round the clock help. I think we're going to need to really expand assisted living. Now, the double-edged sword there is that if we say, okay, let's let the federal government get involved, well, then you're back to all the regulations of skilled nursing. I think it needs to be state supervised, state organized, but we really need to create a lot more boarding cares, let people, get and operate, boarding cares, small hiring and living situations, where there's some supportive assistance. But, otherwise, as taxpayers, the burden is going to be ridiculous. And there's not going to be enough beds.
The silver tsunami's coming. That's what I heard.
That's why,
So
that's why,
it's
that's
coming.
why I go to the gym. That's why that's why I eat my protein, collagen, peptides, creatine. And I'm staying among the living, and that's why I'm doing stuff like expert witness work and keeping you got to keep your head in the game.
Well, I see a lot of 70-plus-year-olds all day. I think you're doing pretty well. I see a lot of
We
younger
do.
people who are in worse shape. So I think you're doing great. People love to talk about AI. So I'm going to keep that speculation hat on. What do you think's going to happen with AI in nursing
I
homes?
think at times it'd be very helpful for us to try to understand what may be going on with somebody. Because when you don't have when it's not really simple, clear lab values, I think AI supported imaging, I think AI supported pathology is going to make a huge difference. Actually, I think it's going to benefit people before they ever need to go to a nursing home, because I think AI, in terms of diagnosing, cancers at a very early age, from the pathology, and everything's digitized, and so pathological, the specimens can be digitized, that can be looked at anywhere in the world by specialists. So some of these really complicated things that end up feel like they don't have a solution, people become disabled, frail, whatever, and they end up in skilled nursing. I don't know that the AI is going to be a predictor about who's going to fall. I think, history of fall is still the best predictor of who's going to fall. Beyond that, I don't know. But I think in terms of diagnosing diseases of all sorts, whether they be, the brain, of the muscle prone, whatever. I think if I was an ologist, I'd be afraid because I think AI, primary care doctor and AI is going to put the cardiologist out of business, or the nephrologist
Yeah.
out of business because, the tests will be fed into AI and the primary care doctor, well, this is the way to go. That's I joke about that when I first showed a presentation about 18 months ago about the future of AI in healthcare, and I'm thinking, man, it's a bad time to be an analogist. But for us,
Yeah.
AI can't provide incontinent care. It can't make sure people are well hydrated, that they're well fed.
As we wrap up here, Rob, let me ask you this. What's the one piece of advice you'd give for every nursing home
Well,
operator?
there's two things. My philosophy has always been if you have an empty bed, fill it because the marginal cost of versus the marginal return of that additional bed. I don't care what the Medicaid rate. Let's say the Medicaid rate is $250 a day, and you have that extra bed, and you fill that extra bed. Almost all of that $250 has been flowed to the bottom line. So that's $7,500 to the bottom line. Boom. Who wouldn't like that? You got 2 or 3 empty beds you can fill in, as long as they're, appropriate long-term care Medicaid patients. I take it. I just think always know what you don't know. Ask questions. Talk to your clinical, regional clinical resource people. Just ask questions. Always be a sponge. Go to meetings. Go to Cal TCM. That's an excellent, resource. And just don't. You got to do more than just talk amongst yourselves. Learn from the physical therapist. Learn from the occupational therapist. So I spent again 8 years in inpatient acute rehab. I learned from neuropsychologists, from physiatrists, from PT, OT, speech. I really learned. And when you do that, you'll be more successful. An operator, make sure that your staff have the resources they need. And it's everything from making sure they have adequate, towels and washcloths to equipment that works. And that's one thing I'll tell any administrator. Do not rely too much on your maintenance guy to be fixing the oven, be fixing the washer, be fixing things that they have no business fixing. They'll waste an entire day and they'll finally tell you at 4 in the afternoon, oh, I can't fix this. I guess we'll have to call an electrician. I guess we'll have to call a plumber. I guess, no. So, but I think it's so important to have equipment that
Yeah.
work because when you have equipment that work and staff see that you have lifts that work, equipment that work, they know that you respect it. At the facility level, at the organization level, that's what it's all about.
Well, thank you so much, Rob. It's been awesome to
Well,
have you on the
thanks.
podcast. Any hot takes before we end this? Anything you want to get out there that
No,
you
I'm
want to
just,
put your stamp on?
again, I'm in semi-retirement and I'm making myself available to those people that feel like they can use some help in an interim type basis or use a fresh set of eyes to look at something. I'm available. I'm kind of a known entity. Love me or hate me, I'm kind of a known entity. But I just, it's all about the staff. It's all about, the residents and providing good care and being good, responsible members of our community. So I appreciate it, Devin. Thank you
I
so
love
much.
it. Love it. Thanks so much, Rob. Thanks everybody for listening.